My name is Mark Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I am a thoracic medical oncologist, and I'm a member of the Institute's thoracic oncology program, actively seeing a large volume of lung cancer patients, as well as continuing many clinical investigations in the thoracic malignancy space. What are reasons why patients are not candidates for immunotherapy despite favorable molecular test results? The standard of care in advanced non-small cell lung cancer is comprehensive molecular testing at the time of diagnosis in stage 4 disease. We have now 7 approved, FDA-approved targeted agents for molecular subsets of patients. You can't get access to the targeted agents unless you make a diagnosis of the molecular finding. The molecular subsets of patients tend to be those patients concentrated in the never or light smoking population. They tend not to get the benefit from immunotherapy that we've seen in the non-driver populations, which tend to be more smokers. Remember, smoking in and of itself is a reasonable biomarker for the benefit of immunotherapy. Having said that, there are a few of the driver populations, such as BRAF and perhaps KRAS, which we don't have a targeted therapy yet, but a couple are coming soon, that tend to get greater benefit from immunotherapy than, say, the EGFR, RET, ALK, ROS1 sorts of patients, NTRK patients. So there's a little bit of differential in that molecular subset. Now, let's say you don't have a driver. What are the things that would cause me to avoid immunotherapy in that population? Well, the things I get concerned about are any degree of underlying interstitial lung disease. I think that that was a major exclusion criteria. I think we underestimate how often we see that in our practices in this population. So that makes me nervous in terms of that, particularly patients who are symptomatic from that point of view. So interstitial lung disease that's symptomatic would be one red flag I would throw up there. Any autoimmune condition that has required ongoing care by another specialist and has required autoimmune type therapy in the past, and that could be anything: steroids, other monoclonal antibodies, other agents that are used to control that. I generally have a discussion with the other subspecialist in terms of the risk and the benefit of this, and there's variability in terms of how the other subspecialists feel about that. You have to make a decision. Are you more afraid of a exacerbation of the autoimmune illness, or are you more afraid of the underlying lung cancer? And then kind of make your decision based on that. Certainly, if a patient has had exacerbations of their autoimmune disease that have been serious, if not life-threatening, then that would make me have a great deal of angst about recommending immunotherapy in that population of patients. More often, you're in a situation where the patient may have had some ongoing treatment, but really has never had a serious complication of the coexistent autoimmune situation. It's interesting that many of the other disease specialists, whether they be rheumatologist or hepatologist or gastroenterologist, tend to be more afraid of the lung cancer than they are of the disease they're taking care of. And so we have proceeded with immunotherapy in some patients with coexistent diseases that would have excluded them from the pivotal clinical trials, clearly would have excluded them. So this is outside the box, if you will, from a clinical trial perspective. Insofar, knock on wood, we haven't been burned by that yet, but obviously it's not a huge number of cases in which we might be thinking about that. So those would be the primary factors that would make me consider not using immunotherapy. Otherwise, I think immunotherapy, whether we use monotherapy in high expressors or whether we use various combinations with our standard chemotherapy regimens, really has changed the standard of care significantly. And so I really try to offer it to as many patients as I possibly can. And as I mentioned, some of these patients may not have been eligible for the initial pivotal trials of chemotherapy because of some of their comorbidities. But I certainly want to give the patient every opportunity to get their lung cancer under control, because that typically is what drives their overall survival from the diagnosis of when they develop advanced stage non-small cell lung cancer.